the way you get to market, there's de novo, there's, pre-market, there's also the 510K. So if you're based on a device that's based on a device and everyone has the same design flaw that's not, controlled within that post-market surveillance at the beginning, everything's probably going to have that trailing effect, right?
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Ryan Bass, CEO at Carrier. And Larry, this is almost like a part 2 to our inaugural episode talking about the MAUDE database. And I'm titling this one the MAUDE Pod.
Yeah, it's a really apropos title. I want to talk a little bit about the MAUDE data and how we can build incentives into ensuring that the MAUDE database, that is the database that houses adverse event reports involving medical devices, we want those data to be more thorough, more complete, more accurate, so that they can really be used additionally for trending purposes and to identify otherwise undetected risks that a medical device may be posing. So let's talk about the problems, what are the gaps, and what are the solutions to optimizing the MAUDE database and improving public health.
All right, we're going to be right back after a short break with Ryan Bass. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Ryan Bass, CEO at Carrier, and I'm just going to term this episode the MAUDE Pod because I just think that's so catchy. And this is not our first interview about the MAUDE database. As a matter of fact, we kicked off Transmission Control with an interview with Christina Jewett about a hidden MAUDE database. And so I'm going to look at this as somewhat of a part 2 to that, but maybe less of what's going on behind the scenes with the information, but we're going to start talking about the accuracy and how to use the information. And so, Ryan, I'm so glad you're coming on. We actually just had you on one of our sister podcasts, and we talked about, messaging to patients, and you and I got into this conversation afterwards about the MAUDE database, and I said, who would love this conversation? This is my co-host, Larry, on Transmission Control. So thanks so much for coming on.
Oh, I appreciate it. It's like I told you earlier. It's like, I think there's a lot of paint missing behind my computer because I've just talked it off as I get into these conversations. And, anytime we can talk about device, whether it's from the manufacturer or down to the patient and back to the manufacturer, always happy to have those conversations.
So, Ryan, maybe we can start from a very kind of 30,000 foot perspective, and then we can get more into grassroots. When you're doing your work with the MAUDE, maybe first you can explain what the MAUDE kind of universe or database is, and how can the database help us, and how does it hurt us maybe even?
Yeah, for me, I would say the MAUDE is an incomplete solution. That's a good idea, but it's just executed poorly. Not for the sake of that all the pieces were available at the beginning of the MAUDE, but today, now that we're pushing into requirements within the hospital EHRs, discrete documentation for UDI and things that weren't there 15 years ago with the UDI rule, the MAUDE database being primarily free text is a good idea in theory, but then you get a lot of people who don't understand how to spell Stryker or what their serial, their lot is. And you still have a lot of free text blanks that people just leave, and then you can't really do any analytics on it. So we're in this nice transition from the free text beginnings to a discrete kind of format. And that's where the interest comes in from carriers. How do we work to populate that MAUDE database so that other companies can do the predictive analytics and we can work with them so that we can make medical device, recalls, field notices, standards of care, all of those things flow more seamlessly with data-driven backing.
So when you do a patient alert, or your kind of the activity you're engaged in is notifying the public of the risk, of some type of a medical device, you're going into the MAUDE database, and then is the MAUDE database really the primary source of what's allowing you to then say this device is risky or not? And I'll just end that question by saying when I read the FDA's disclosures, they say these data are inaccurate, they're incomplete, and really can't be used for trending. And then there are instances very much, for example, with flexible endoscopes, urological endoscopes, duodenoscopes, where bronchoscopes where indeed the FDA did use MAUDE for data trending. So I'm a little confused about kind of these two sides of the coin the FDA is presenting, saying these data are incomplete and kind of useless, and yet the other side saying we use these data and they're important. Maybe you can speak a little bit to that and just tell us what, in terms of the MAUDE database and the results that the analytics it's providing, where have you gone with that? What have you accomplished with those data?
Yeah, it really comes down to what do I say and what do I do, right? And so there's the legal understanding, and then there's the understanding that I'm doing to try to be proactive and predictive of what's out there. And so the biggest limitation and why they're saying you can't use it is because of the free text, the incompleteness. They estimate that less than 10% of adverse events are actually reported, and I would say it's even less than that. I could go into a whole story where I was getting an Uber ride and someone was telling me about their insulin pump was burning. And I asked them, did they put an adverse event report in? And she's like, what's that? And, it's like she called the company, but the company's not going to go tell on themselves and put it into a public database. And so even then, they don't know what serial lot if she doesn't tell them what it is. So the actual scope of what you can do analytics on is very limited. And so what Carrier's focus is we're pulling from these public databases, but we're also promoting how to make them discrete and have data integrity. So we're pulling from the recall database, like we met with the Open FDA the last 2 times in the last 2 weeks about how do we help them get better data, but how do we get more data out of their systems that are useful? And then on the other side of it, how do we help patients and how do we help providers populate MAUDE? And then let companies like what you're doing, Larry, and be able to extract real data and have integrity with that to know that someone's not spelling Stryker with an I. And you're like, is that a second company or is that Stryker with a Y? And where do those intersect?
So one of those things that you're talking about is not getting enough information. How do we make sure that people are funneling the information in? But sometimes when you go and mine it, and I'm sure Larry will back this up, some of the reports are really innocuous to the device, right? There's situations that might have come up. It could be human error. And not that that isn't valuable data, but it might not be safety related data. And so, how we already know that there's a manpower issue, in just managing this database to begin with. But then if we start funneling in all of these reports, even from the consumer who will be even less informed about the situation when they send that information forward. And I don't think this should be a deterrent. So I'm definitely not challenging that. I think more reporting and more data is better. But how are we going to sift through that when nobody's really able to qualify or categorize these reports as they're coming in at this small percentage from the providers to begin with?
Yeah. So, it's correlation and causation. And then there's also customer complaints, and then there's adverse events. And I think we have to distinguish between all 4 of those things, right? So there are confounding variables that run awry everywhere for everything, right? Like I'll use the Philips CPAP example that's out there right now. Between April 2011 and April 2021, there were 30 MDRs submitted globally, right? Only 8 in the US and 0 were related to death. From April 2021 to April 2022, when somebody went, hey, this sound abatement foam is breaking up and people are inhaling this, there were 21,000 MDR submitted and over 1,300 deaths directly associated. So you extrapolate that out over the last decade and you say, we missed 210,000 device reports that we could have proactively went out and caught this earlier and saved, at least 1,300 deaths in this last year, right? Or been able to, cut the number of CPAPs that were out there because we identified it 2 years in as opposed to 10 year. And now it's more manageable to get those off and replaced and fix the issue than to now look back on it a decade later and go, well, what are we going to do now? We're hoping to fill out, the response by end of year, but we don't know.
So, Ryan, what caused critical mass? Why all of a sudden do we have kind of a step function? We have 0 deaths, and all of a sudden then in 1 year, we have all these deaths that you just mentioned. There's a problem there. Can you explain that problem a little more and then what the solution is?
That's the correlation, causation, customer complaint, adverse event. So I'll use another example, the cobalt and cobalt metal hips. those were rubbing off and causing metal cobalt flakes to go into the tissue. And that was causing dementia-like symptoms. And so patients were getting written off that they were dying from dementia. And then what happened is there was a physician in Alaska named Dr. Tower. He went to a medical conference, lost his cognitive thinking and destroyed a hotel room and was like, oh, something's wrong. Went back home, took his urine and blood analysis and found out he had elevated levels of cobalt. And he was like, the only thing I have cobalt in my body is my hip.
So he knew.
They removed it. Yeah, they removed it. And then they went, oh, all your dementia symptoms and all your cloudiness is gone. So then they were able to say well, maybe there's something here. But until you actually make that gap and bridge it, it's something that you can't contend with something that you don't know is there, right? You're battling the unknown. And until it's known or you can make that connection, you're shooting it in the dark.
So you're saying it's the unknown. Let's discriminate between three particular parties that are involved here. We have the patients that we've been talking about, the consumer. Let's call that party one. Then we have the hospitals or the medical facilities, party two. And then the third party is the manufacturer. So there's certain devices where, for example, the insulin pump you were talking about with the Uber, this is a device that this person is carrying around and interfacing closely, choosing to use visually, observing its function day to day. With flexible endoscopes, for example, though, that's not something that anyone is seeing. Simply the hospital takes a device and uses it on them. So did the manufacturer in the CPAP case, not necessarily the consumer reporting these problems, but was the manufacturer aware of them? I would think the manufacturer was receiving reports. Why did we have no reports and then all of a sudden critical mass with reports? Again, what was going on there?
I mean, it's a lot of guessing, right? But you also look at the average cost of a recall is $600 million. You know what I mean? So if you're going to do a full-fledged recall globally and pulling them all off the shelves, that's expensive. So it's kind of one of those things of what's the cheapest route and how do you know for sure that this actually is causing it until you have, real intelligible data, right? And so the system's set up today to be free text to where it's a lot of guess and check. It's trying to get those outcomes associated. It's all the confounding variables. Is this CPAP device the actual root cause? Or are there other things that are contributing to its issues?
Well, I believe the regulation states something to the effect, you can correct me if I'm wrong, that when adverse events are occurring, there's trends, such as with the CPAP machine, duodenoscopes, that when there are those trends, the manufacturer, I believe it's pursuant to federal law, is required to do a root cause analysis and determine what it is. So we can hypothetically say, well, we don't know what was causing it. It could have been one of many things. But in the case of the CPAP, for example, didn't someone know exactly what was causing it or not?
I mean, I would expect them to have had, I wasn't in the room with Phillips. You would expect them to have thoughts or theories. But again, until there's something that says black and white, this is it, and there's no other option, if I'm looking at it objectively and not saying that manufacturers are evil, but if I'm looking at it and it's going to cost me $600 million and I'm not 100% sure, I'm probably going to err on the side of, well, let's just keep looking. You know what I mean?
Isn't that where the FDA comes in and says we're looking at these reports, we can go in and do internal review of the data, not necessarily external review of the MAUDE database? And would not the FDA, is that not their jobs to analyze during inspections a manufacturer's data to see if the manufacturer is discretionarily making a judgment call different than what a regulator such as the FDA might make?
I mean, and I'll answer that with another solution where they're supposed to keep all manufacturers within a signal involved, but they've publicly said many times that sometimes signals get too large and they can't keep everyone informed. And it's like they should be able to CC or mail merge. You know what I mean? There's a lot of things that are out there that are pursuant that they're supposed to do versus what they actually follow up or what the hard data allows them to do or the manpower and all of these different contributing factors. And it's all really driven back to the manual processes, right? It's not having automation. It's having free text. It's having manual work process.
Can you give an example of a device where there was a plethora of data in the adverse event database, and yet there was this lag between the adverse event, patient injury, and the FDA actually notifying the public?
I mean, everyone knows. I mean, you guys did the first episode around the hidden FDA database. So you start looking at dentals. I mean, innately with any medical device, right? Any medical device that's an implant, it's a foreign body. So no matter how much testing, no matter what you do, it's a foreign body reaction to something going in your body. And there's gonna be a fraction of the population that comes into contact that's going to have adverse event reports, right? That's just part of doing business. So it's what threshold is acceptable, and then what actually causes for the escalation, and how do you basically control for these adverse events that are going to come, right? And so I think the dental implants is probably the most notable area of where they were hidden and the public wasn't available to be told. But at the same time, there's a gap between who's actually responsible. And I'll use Allergan breast implants, right? Allergan, the manufacturers are required a track order to tell those patients, but they've done acquisitions, patients have moved, contact information, data retention policies, state by state change, and data gets deleted. The manufacturer no longer has it. It's in paper. And then they don't notify the patients. Well, then the way you hear about it is on Facebook or a local news story. And then patients are asking, well, why didn't the FDA tell me? You know what I mean? They're the ones telling the manufacturer to do a recall. Why didn't they tell me? But again, it's not that the system doesn't want to notify. It's just that it's not set up efficiently to be successful to do that. The free text, the extra work, the manual process adds cost, time, and extra work to everyone. And then it just causes burnout and people to drag.
So you were talking to me a lot about signals. And can we just define what signals are, and then we could talk about the implications of the various signals?
Well, I mean, a signal is just like, when you start getting a lot of adverse events, you start getting a lot of like things back into the manufacturer. You start getting out these like, well, is it device specific? Is it across, a whole type of devices manufacturer? So you're looking to see like, what's the scope of who's impacted with these different things. And so that's going to vary depending on the device or the product code or how big that range is, because the way you get to market, there's de novo, there's, pre-market, there's also the 510K. So if you're based on a device that's based on a device and everyone has the same design flaw that's not, controlled within that post-market surveillance at the beginning, everything's probably going to have that trailing effect, right?
So you were talking a lot about data integrity, and then, how do we use that data if it all of a sudden we get big sets of data? Like, how are we going to kind of mine that for an appropriate action or response? But right now, current state, what happens when these signals get too big like that? Because I'm assuming that in certain circumstances, even like you just described with the CPAP, right? All of a sudden there's this influx, and it might be more than the system can handle. So in current state, what happens right now?
Patients suffer. I mean, end of story. Like, that's the end of it, right? So, another example is the Cardinal gown recall, where they were non-sterile gowns that were being shoved
at the worst possible time. Like 4 months before COVID hit, and then all of a sudden we needed gowns and PPE left and right, and we didn't have it.
Yeah, and so then at that time you look back and you say, well, who came into contact with these gowns? But no one's actually going through and documenting in the workflow what gown was used in which place and which batch, and, which grouping of devices were pulled out that were sterile and non-sterile. And all of a sudden the patient doesn't get that information, but the hospital gets notified, and then they go, well, what do we do with this? It's like, you're giving me the haystack and telling me there's a needle in there, right? Like, who is at risk, highest risk here? And so it's doing that proactive approach, right?
And hospitals are in a precarious position too, because of HCAP scores. So you're basically telling them that even though this wasn't in your control and you didn't do anything wrong, you're about to hang yourself, financially or fiscally, because you're about to get impacted by reimbursement, because you're going to go out there and tell everybody you did a bad job, but it wasn't really anything that you did, but you're the face of the outcome of this.
Well, let's compound that. So like, not only do you have your HCAPs, but you also have the fact that you might have a outcomes-based contract with a manufacturer that their device is being used, and you're getting surgical site infections and you're having negative outcomes for the patient. And that's going to drop your compliance to that manufacturer's devices, which is going to make you pay a higher amount in your agreement with the contract. So like, you're damned if you do and damned if you don't. You know what I mean? Like, both sides you're getting burned on. And it's at what point does it come to a fruition point of like, hey, data is good when we can be proactive with it, instead of trying to scramble and, write free text things down and scan and fax and then say, oh, we'll dig through vanilla envelopes later, which will never happen. You know what I mean?
So don't we have forces, and I'm just drawing this conclusion based on what I just heard you say. I want to try to summarize what you said. Don't we have forces then that if there's a quality issue that understandably The hospital does not want to have its ratings or its image diminished in any way by a device that isn't working properly. And we have a manufacturer of that device who you say could cost hundreds of thousands of dollars for a recall. Isn't the system doomed in that, going back to the three parties I talked about earlier, the hospital has an incentive not to do anything, the manufacturer has an incentive not to do anything, and the patient often isn't even notified that there's a problem. So it seems to me we're talking about something that I'm not so sure that it can even be fixed and optimized. Can you comment on that?
So the biggest thing that's changed in that recent history is that we have the 21st Century Cures Act, which essentially says that patient data is patient data. So hospitals just reside over the data, but they don't own it. It's patient level data. And then to basically go around and needing Congress to approve any new data points that are then required, the 21st Century Cures Act adopted the US CDI, or United States Core Data Interoperability Code Set. That then included the UDI, or Unique Device Identifier, as one of those data points. On the same time, about 2015, there was 2015 CERT that came out, or Certified Electronic Health Record Technology, that health systems were required to be compliant with by Q4 of 2019. And so part of that was having a discrete data field for UDI. So now within the medical device, workflow and sphere, we have UDI law, and you have the barcode labels that are human readable and scannable, your ICBA, your G10, and your HIBIC. And from those standard labels, you have those. They then transfer that information into an electronic format in your EHR, which is required for the hospital to document against to comply with information blocking. And information blocking is a whole prerequisite to be able to submit to your meaningful use money. So there's this tangled web of regulation that runs across different regulating bodies, from the FDA to ONC to CMS, that's Federal Food and Drug, the Office of National Coordinator, and Center for Medicare and Medicaid. And so now we have these three bodies that are starting to kind of intertwine and create a workflow where data is required to document throughout. And what that does is now it includes information in your legal medical record, with an understanding that when a manufacturer tells a hospital, the hospital gets that information and should have that information of who the patient is, that can go down the stream, right? And so now it's how do we automate that process? And that's really the big gap that I saw and why I started Carrier. It's we have this interoperability opportunity from these three different disparate systems where we can interlink these requirements and create this entire system that everyone benefits from. So to summarize that, there's new regulation that health systems are really wanting to meet because of their bundled payments and their accountable care organizations and their Medicare shared savings plans. And so they're wanting to be proactive to be compliant with meaningful use, or now promoting interoperability, which is their largest reimbursement, right? So if that's the most money I'm getting, I want to make sure I get that full reimbursement and not lose 25% of it because I didn't document certain data points.
Okay, so did you think then that with all that very important information you mentioned, did you see that working with regard to the CPAP recall, or is the CPAP recall kind of a different striped animal?
So the biggest thing within the requirements is it's within an implantable list log, right? So it's more your implantable stents.
That's an important clarification.
Pacemaker batteries.
Okay.
Yeah. And so you have your DMEs, you have your disposables, but workflows can be created, right? And so we had our first client sign on 2 weeks ago, and we'll announce that, in the next couple of months with a joint press release as we get going with them. We have a couple other LOIs. We have a couple other very large systems that we're meeting with next week that are very interested to use our platform. And so it's really working with them because there's an ROI, right? There's the ability to do analytics and find surgical site infections and what are those compounding variables that are the reason that they're having repeat offenders and losing millions of dollars because payers won't reimburse because they had to do a revision and they had a surgical site infection that could have been prevented. So there's a lot of value to the health system. There's a lot of value to the manufacturer where that $600 million price tag is out there. But ultimately to the patient, there's an immense amount of value to being able to be included in your health decisions, right? And be informed and know that, hey, I got an IVC filter. If I don't come get this taken out within, the required time period, it could scar or calcify into my vein and the leg could break off and pierce the internal organs. That's something I want to know, right? But today, UAB did a study in 2018 that found that 55.3% of patients were lost to follow-up, and there was no action, right? There's nothing to get them to come back in, and then that causes higher costs down the line. So as we continue to move from fee-for-service to value-based care, these things are all going to become more important because it's going to save money for the payers, the health systems, the manufacturers, the distributors, and improve patient outcomes.
Okay. That's very interesting. And we're talking about implants now, which was a clarification. And do you have can you discuss in that context a physician's office where maybe a patient's undergoing a procedure that does not necessarily include an implant? Is that something we should just table for now? Let's focus on implants. Let's get everything, all the kinks ironed out, and then we can move on to other types of devices.
When you go to the grocery store, right, you scan everything, right? Everything has a UDI. There's a requirement for the UDI law to be met, like Bebron pumps, the pumps that are used in the room. Like, if that's being used, we should have a way to follow the tags that are the receivers of which room that it's in, associated to a patient level, know what level of software it's on, if there's any vulnerabilities, what patients came into contact with it, what are the mediation steps. There may not be mediation steps, but having that information allows for us to be proactive in how we're treating patients. It's that zero harm or like true north approach to healthcare, right? Like, we want the patient. That's what healthcare is built around. Like, I know that it's a big business. Lots of money comes in and out, but your physicians that are doing it because, hey, there's this huge, most of them aren't. They're not doing it because there's this huge paycheck associated. They want that bedside rapport. They want to help people. They want to have the best outcomes for them and help them. And so how do we on the tech side empower that? And that's really the kind of next step we're getting into in healthcare, where phase one was, let's make sure we're doing all our billing, right? Like rev cycle is the furthest built out, and that's what everyone, keynotes on. But now when we get past rev cycle and we have this database, let's stop making the physicians just be data entry monkeys and say, here's data that you can work with. Here are things that we can present, still let the physician make those decisions, but give them the most information. So if a patient walks in and they're presenting with large cell lymphoma, and I don't know they have allergan breast implants, which is known to be causing large cell lymphoma, and I'm sending them to cancer treatments without removing the source because I don't know, that's setting everyone up to fail. Right?
Yeah. So you do kind of advocate a phased approach, like Larry was suggesting, just not in terms of data collection, but more like data utilization and action stepping or alerts or awareness, because a lot of what you and I talked about last time was messaging to the patient. But what you just got to was how do we message and actually get into those sort of like care decisions and care delivery insights for the clinicians that could come from this, because there's no way they're all going to be able to memorize this. They need a technology to say, this is a potential situation based on the data that we have, and you should explore it so that they can be efficient with their time and then do the critical clinical application of that. With that, once they have that information, they can then do something with it in the context of their expertise. So I think that's really important. It is kind of the purpose of UDI. I see limitations similar to the MAUDE database with UDI as well in some scenarios, but boy, what a huge first step. And even the rev cycle component of it, this is almost a reverse of what you're saying. Rev cycle is almost the other way around. It's like we've kind of figured that out from a data standpoint. We still haven't figured out how people can actually use it organizationally because it's still very siloed instead of being broad and sweeping with contract compliance and everything else. So I think you could draw some parallels there with how you would phase sort of the implementation of the next steps by getting this data and using it properly.
Well, and I'll add one more thing. So like, instead of looking at it from like the internal med or the primary care usage of like diagnosing a patient from that perspective, like think about when a patient is on vacation or they're a snowbird and they get a pacemaker, right? And then they go back home and then now they have an event where they need an MRI, right? They go into the hospital, and I don't know if you guys have had MRIs, but I played college sports and I've been injured a few times. So I get, the MRI piece of paper and it says, what devices do you have in you? And you have to go through the checklist and say, what do you have? And then the next thing is like, if any, what is it? And if you don't know serial, lot, batch, manufacturer, and is it MRI compatible, safe, or, there's any other things that you have to do to make it safe or conditional, then now all of a sudden the hospital then has to go pick up the phone, call your previous care provider, see if they have it. If it's cardiology, get in touch with them.
You want to cut out the middleman. You just want to cut out the middleman.
Exactly. So if we get into a situation where everyone's playing at the same table and we have the bidirectional interfaces, which are already happening for like Florida shots and other shot registries that are happening state by state, we can actually empower this data to flow for patients and for providers without needing to pick up the phone, right? Like, let my system do that. Like, that's an established technology.
So in our closing moments, Ryan, can you discuss how patients, can there be advertising or some kind of marketing directed at the patient? You were talking earlier about the CPAP machine and patients not, or the Uber driver with the insulin. We as patients are not notified by the government, or it's not imposed on us, or it's not made aware to us that these forms, for example, the 3500 form that I think Justin wanted to touch on, these forms that we're to fill out, we need someone telling us, or an organization, an agency marketing to us that this is available and what we need to do. And that's not been done, so no one really knows about this, and so no one can fill out a form, and so there we are.
Yeah, it's a push, right? Like, that's where we're working with health systems to empower patients, right? And it's that at that 2 level, right? Customer complaints versus adverse events. Like, if I'm putting in a knee for someone and someone says, well, after my knee, I got a urinary tract infection, like, it's probably not the cause, right? Like, we can store this away, but we don't need to fill out an adverse event report for that unless we start seeing a high amount. And then we need to figure out why everyone's getting a UTI from a knee implant. But like, those things don't get pushed out to patients, and patients just suffer because they feel like that's what's supposed to happen, right? It's like, they just cut me open. It's like, if you've ever seen a spine surgery, it's like they had a hammer, right? Like they are going at it with a block. So like, of course you're going to hurt and you're on pain pills. So you just assume that that's net normal and that's the new you, right? And so we want to really empower those patients to provide that feedback back.
And how are you providing those patients? Through the hospital or direct marketing to patients?
So through the hospital, because that's like, I read a statistic where there's only one thing that's depleted more than the physician and patient relationship, and that's between the general public and Congress. So like, the trust factor is diminished to an all-time low. And so there are already structures in place that are patient portals. Like for your COVID result, you had to download a MyChart, right? There was no way around it. You had to. So we have these mediums that are trusted and understood between patients and providers. So let's do that, right?
Okay.
Like,
Tap
we even
into
provide
that.
an electronic implant ID card through that and push stuff to patients and say, if you're having issues, use this medium so that we can then be proactive to this approach and identify things more early.
So naturally, if you're engaged in healthcare, this just gets plugged into the infrastructure of it.
Yep. We become a sunk cost and like a standard of care across what patients expect. And it's a global problem, right? Like, we're focused US right now with blinders on, but this is through EU and Asia and Northern Africa, like the Middle East. This problem exists.
Right. Everybody has this problem. This isn't a
Correct.
United States problem. Everybody has this problem.
Correct.
Yeah. And honestly, the advancement of medical devices and instrumentation and the complexity and everything else it's exponential growth at this point. Like, so a lot of this stuff is happening so fast and to the benefit of most of the patients, right? Like mostly to the benefit, but it's happened so fast. There's so many things we won't know for quite some time. What I like about this conversation is let's get as much data in as we can. So like what you said with the CPAP scenario, we can mine that data and just be more proactive so that we can keep up with this rate of change related to the advancement of healthcare and healthcare technologies. I mean, Larry, I don't know if you want to add anything, but I think that's the essence of the conversation.
Yeah, I think it is. And then we have the data. So then we want the data to be accurate, integrity of the data. But we need to have all incentives for all the parties to provide the data. If there's a disincentive to providing data, then we're not going to have the data. We have a problem. And that's something that I think we still have to have continuing conversations about, because if the hospital can be harmed by the data, the manufacturer can be harmed by the data, then, I'm kind of wondering how much of the data can really get out there for the patient to benefit from if there's disincentive not to provide the data. So we need to get the data out there. We can then mine it, but we need the data to be complete and accurate, and then we can go from there. And I think that's an ongoing stumbling block is to how to build the incentives into getting all those data out.
Well, it's the legal protection, really, right? I mean, at the end of the day, the FDA has really set up the ability for manufacturers to, it's a bad, I guess, saying in this situation, but it's like to make an omelet, you got to break some eggs. So if we want to push the bounds of what the medications and what the medical devices and what we can produce out and push out and provide a service for everyone, there are going to be stumbling blocks just innately, right? That just in anything innovation wise that happens, period, hard stop. So with that, it's just, hey, how quickly do we respond to that, right? There should be punishment if, hey, I know there's a problem and I'm hiding it and I'm doing nothing, but hey, we found out this is an issue and this is how we're addressing it. And this is the speed and time in which we're able to get the information, identify follow-ups, and be able to find a path forward. That should be cheered on, right? Like it shouldn't be, condemned if there's a mistake, if we're going in the right direction. It should be, yeah, there's a mistake, but it's a step in this direction where generations beyond us are going to reap rewards and benefits that we can't even imagine, right? But if we're too scared to innovate, we're too scared to push those bounds, we're stuck at the technology level that we have today.
Ryan, fantastic interview. Great job. Great job. Anything you want to add before we wrap up?
I think that from my perspective, the industry as a whole has looked at this very mono silos for this is how I'm going to fix it. Correct. Yeah. And so looking at it in that regard, there's not been like a revolution or a power of magnitude change in the industry as a whole outside of, I'll say, the UDI rule, right? And that came from regulation. And to your point about disincentives, the manufacturers don't want to share all their data intrinsically with the people who are their punisher, right? Like They don't want to put all their dirty laundry out there.
Right.
And so the way we have to kind of maneuver this is we have to come to an agreement to where there are things that are shared and there are levels that are shared that trigger different events. But there has to be kind of this like ability to use the same platform without sharing everything freely, but having the ability to have these thresholds that are agreed upon that trigger other events. And so it's going to be a tightrope, especially when you look at like MNUFNA, like where the FDA gets funding from, right? So like, how do we keep manufacturers happy and the FDA happy and ultimately give the best outcome for patients? And that's really the goal that like I have on the horizon is, how do we really give the best outcome for a patient so that you're getting the best service, the best outcome, and the best quality of life that you can get?
Excellent.
That was Ryan Bass, CEO at Carrier, and we talked a lot about the MAUDE database, but really more on the data side of it, not so much, hidden data or what the implications are that way, but really just some opportunities to take the data, make it meaningful, gather additional data. And Larry, I think you were really touching something on there, though, is for us to get more data, we've got to have alignment on the motivations. And that may be a struggle for the industry to get an alignment on that, but it's something that's truly necessary.
Right. The incentives have to be in place to move this forward. And if there is a disincentive to moving forward and to improving the integrity of the data, then it's going to be a struggle to get the data improved. We're talking about the enhancement of the communication of the data and how to optimize that communication. But in addition to the communication of the data and enhancing it, we need to also make sure that the data themselves are accurate and complete. So we have the optimizing the integrity of the data while we're working on improving the communication of those data. So those are two important pieces here, but the system has to be aligned such that there's incentives for everyone to work together and to put out accurate data and then to properly ensure that the appropriate stakeholders are provided with those data.
Yeah. All right, well, that's going to do it for this week's episode. But as a reminder, you can support Transmission Control by subscribing on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or simply search for Transmission Control on your favorite podcast application. You can also access bonus content for certain episodes, but you've got to download our smartphone app for iPhone or Android. And while you're there at the app marketplace, we'd certainly appreciate a rating and a review because your feedback is important to the show. On behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.